Thank you.
Welcome to the YWCA's Talk on Health. This is a monthly conversation with the experts that's sponsored by the Lower Cape Fear YWCA. I am Dr. Lekeshia Jarrett, and I'm a family medicine physician for Wilmington Health in Leland. Thank you for joining us today. We have Dr. Khadijia Tribie Reid, who is a pediatrician at Mid-North, and Ms. J'vanete Skiba, who represents the New Hanover County Resiliency Task Force. Thank you both for being here. Could you please tell us a little bit about your background and how that makes you uniquely qualified to discuss this with our audience today? We'll begin with Dr. Tribie Reid.
All right, it's a pleasure to be here today. As you already stated, I'm Dr. Khadijia Tribie Reid. I'm a pediatrician here in Wilmington, North Carolina. I've been working with community health centers my entire career, which has been 15, 17 years, something like that. I'm a member of the American Academy of Pediatrics Expert Leadership Team on Trauma-Informed Care. So this is the work that I do and that I've been doing for many years, really intrigued and interested in adverse childhood experiences. And this is why I sit here before you today, very passionate about this space.
Thank you so much for being here and taking your time out of your busy schedule to do that for us. And J'vanete, could you introduce yourself?
Sure. As you mentioned, my name is J'vanete Skiba. I'm the director of the New Hanover County Resiliency Task Force. And in that work, I am able to lead a task force of about 56 organizational partners and 700 members on developing a trauma-informed and resilience-focused lens for our community. In my work with the task force, I'm a certified community resiliency model trainer and resilience educator. I have a certification, a North Carolina certification in resilience and trauma, with a focus on racial trauma. And I'm also finishing up my master's of education in neuroscience and trauma. And I get to teach folks all over our community from diverse professional backgrounds as well as cultural backgrounds on trauma-informed approaches, mostly around racial equity-oriented trauma-informed approaches.
Well, thank you very much for taking time out of your busy schedule to join us today.
A pleasure.
Can you all help us to understand exactly what is childhood trauma?
I'll certainly jump in there. I'm glad you asked the question because I think often people think about trauma as like a car accident or this huge dramatic thing happening. And I think it's really important to underscore that trauma is as simple as not having an adult caretaker in your presence consistently. You know, that could be because you have a parent who has a substance use disorder. It could be because your parent is mentally ill and not present. It could be because your parent works too much and they're not present. There's a wide range of things that we call trauma. Specifically, when this work began, we were talking about adverse childhood experiences, which were 10 specific traumas that could fall into about 3 different categories, including household dysfunction, abuse, or neglect. But that has increased in range to include climate disasters, which most of us have been impacted by, or even refugee status. So there's a wide range of things that could potentially be traumatic for developing brains and bodies.
Yes.
Thank you so much. J'vanete, would you please add something to that about understanding exactly what childhood trauma is?
Sure. Dr. Tribie Reid talked about some of those complexities of childhood trauma. And there are many things that can contribute to a child's experience of safety or of threat. And concisely, there are early experiences that can negatively impact a child across their lifespan at various stages of their development. And if there are no mitigating factors or what we call protective factors for a child, it could be really challenging for that child to develop to their full potential. So when we talk about trauma, it's not just, as Dr. Tribie Reid said, this large event or what we can call big T traumas, things that we can all identify as potentially traumatic. But it could be smaller things that activate that safety and threat response in a child to the point where there's that overwhelm. Um, and because of that, trauma is not just the event, it's the experience, it's the long-term effects on the nervous system across their lifespan, and it's also environment. All of those things can contribute.
Thank you very much. And just as a citizen and a person in the community, are there things that I could look for that would alert me to the fact that a child might have some trauma, and how should I interact with them? Do you all have any information about that?
Sure. I mean, I honestly think what we culturally look for are behaviors. Those are those things that are easily identifiable. So that might be an indicator that there is some sort of history of trauma or that that child might be experiencing trauma currently. But I want us to think about not just seeing behaviors, because a trauma response can actually look like the absence of behavior or a low affect, as we might say. If there's stimuli in the environment and the child is not appropriately responding to that stimuli, that might be an indicator that they have experienced some trauma. Um, so it can vary. And there might also be some cognitive indicators. And I know that Dr. Tribie Reid can talk a lot about that, but just to touch on it, there might be some milestones that that child is not getting to in their development. But then even physically, which is important to point out, there might actually be some failure to thrive. There might be some changes in their actual physiology, in their response to stress that can be identified. So the whole person or the whole child, there are so many different ways to observe maybe the outcome of a traumatic event in an individual.
Thank you for that.
Yeah. This is Dr. Tribie Reid. I'd like to express that I agree wholeheartedly with what J'vanete has expressed. I will tell you, if I tell you how I delved into this work, I think it helps people understand what this might look like. So I initially started working locally, and I work at a community health center. That means I work in a space where people may or may not have insurance, often do not have insurance. Often families are immigrant families, refugee families, often experiencing poverty. And in this space, I started seeing a disproportionate number of children that just weren't developing as I would have expected. So I often say these are 4-year-olds that talked like 2-year-olds, or they were 8-year-olds that instead of sitting in their second and third grade classrooms, were crawling under the desk, running out of the classroom. So as you see, behaviors were just not what we would have expected. In addition, I was seeing significant pathology. And so, Dr. Jarrett, when I talk about pathology, I'm talking about physical changes in these children, lots more heart disease, lots more, the asthma was just the worst asthma I'd ever seen, lots more congenital changes. And I was saying, my God, what is happening? What am I seeing in this space? I wasn't seeing that many children, but I was seeing a disproportionate number with significant pathology, changes, things that were evolving in ways that they should not. And so that's when I started to learn about adverse childhood experiences. And I began to understand, wow, my patients are also experiencing a significant degree of adversity, poverty, When we talk about for example, for African Americans, maternal mortality being, so much higher in African American communities, that means my children often are losing their parents or being raised by a grandparent or being raised by an aunt. They're experiencing that. A lot more morbidity and mortality. So there's so much more adversity often that these children are experiencing just by virtue of their space and their place and their ethnicities, their refugee status, immigrant status, that they are getting those toxins, that toxin of adversity. And so I think it's really important for us to think about this as a poison. These adversities are actually poisons that are hitting the developing brain, the heart, the lungs, any part of the body you can imagine. That is what's happening to these children. And so that's what we see. That's what we feel. It could be experienced or seen in any number of ways, and I certainly agree that it could be experienced with the absence of systems, absence of symptoms as well, a low response, less of a response than you would see. So there's a wide range here.
Thank you very much. So are these effects always short term, or are they long term, or is it a mixture of both types of effects that we see in these children?
Yeah, I'll jump in again, Dr. Tribie Reid here. So unfortunately, the impact of childhood trauma can be long term, and often is, and that was the importance of the adverse childhood experiences study, is because what we saw that a child who experienced four or more ACEs or adversities was significantly, disproportionately higher, had a higher incidence of depression and injection drug use and even cardiovascular disease. And so unfortunately, those risks can be higher. Now, sometimes we catch kids a little early and we can throw in some speech therapy or an IEP for a child who's already behind, but certainly consider the cost to health systems and educational systems when we start doing that. The effects are not just physical or socio-emotional, they're also social, because these are often children who may not finish high school, may not be productive citizens, may go on to have significant mental health consequences or increased utilization of the emergency room. So the repercussions of this are wide ranging, but I know you're going to ask us about this later, but I'll go ahead and put my plug in. If a child can have a safe, stable, nurturing relationship, if a child can have one caregiver come in, that can be a grandmother, like I said, it could be a foster parent or an adopted parent, come in and provide that consistency, a lot of times we can start to recuperate some of those skills and some of that health.
Thank you. Thank you. I was indeed going to ask you if we catch these traumas early and we can give children a stable home, is this reversible? So thank you for adding that. J'vanete, would you like to add anything else about the long-term or short-term effects of childhood trauma?
Absolutely. Again, this is J'vanete Skiba. And when I think about how we are starting to have this conversation, how this narrative of community adversity is starting to rise to the top, I think it's really interesting because in the work that I do, leading a multi-sector collaborative or coalition, oftentimes I'll hear in conversation how we are just talking about mental health. And that's not really the case. We are trying to show how all systems contribute to the dysfunction, or how we can actually contribute to mitigating some of those long-term effects. And as Dr. Tribie Reid mentioned, across the lifespan, we're talking about social, physical, emotional, cognitive health overall, behavioral health. And these are parts of the whole person. And so we can use all of those parts, and we compartmentalize really as we try to understand. We want to assign this just mental health, but ultimately it's a whole person issue. And if it's a whole person issue, then we are able to look at it by sector and say, well, if I offer paid family leave, then I am allowing families to do what needs to be done in that first 60 days when we talk about that brain development. So much happens. That is a remarkable time in brain development as far as trauma goes. When we think about a child who has secure attachment, that primary caregiver is there from the beginning, is not stressed out about losing their job, is able to engage and nurture that child and just literally be with that child, even if it's not necessarily the birthing parent, even if it is grandma or auntie. If there is somebody in place to help that child make those connections, what's happening in those moments is the brain is actually building their map of the world, and that sense of safety and threat are being hardwired kind of in the brain. All that circuitry is being built. When Dr. Tribie Reid mentioned neglect as one of those realms where trauma can occur for a child, neglect is actually more harmful to the brain than physical abuse. And when I think about that, and I think of all the different systems that can contribute to the health, the whole health of the family and the child, then I have to be able to speak that language of we have to have paid family leave so somebody can be at home with a child and we're actually changing outcomes down the line. We're not stressing out the education system or the justice system or our healthcare system to the tune nationally. I think I want to say over $700 billion in all of these systems because of adversity, the public health crisis of childhood adversity. So, as we think about the long term effect, we can think of it on that individual level. And there are a lot of interventions and ways of early intervention and prevention that we can actually start to build together. But I also want us to think on that community level and then that societal level of how are we changing systems so that conditions are conducive for nurturing relationships and healthy relationships, because that is really the foundation of preventing childhood trauma to begin with.
Do you have
Yeah,
any
I want to.
examples? Oh, excuse me. I'm sorry. I just wanted to do a quick follow-up with J'vanete about
Sure, sure.
examples of how, as a society, we might make changes that would help with that.
There are so many things that we could start to look at doing. Um, there is opportunities. One, and this is something that we do within the task force, is just starting to get that awareness and education. Let that start to be common knowledge and build a common language around how we can build resilience at the individual level, the organizational level, and the community level. Once people start to build that lens, then it can change how they do the work that they do. We're not talking about, suddenly teachers in schools need to be mental health therapists and nurses and occupational therapists and all of the things that a child who has experienced trauma might need. But what we are asking is that we all develop that lens and understand that, possibly 6 out of 10 children in your classroom might have experienced some sort of trauma, at least one adverse childhood experience. So, in the purview of the work that I do, how can I create trauma sensitive environments? Or specifically in education, what's some trauma sensitive pedagogy that I can include in my classroom and then maybe across my whole school culture and then maybe throughout the district. In healthcare, it's the same thing. It's not just in, and you all can speak to this too, that bedside manner or in my own practice, but how am I advocating for systemic change in how we research, how we treat our patients, the lens that we use as we find solutions and cures for our patients.
Absolutely. Thank you very much. I'm sorry, Dr. Tribie Reid, you may continue.
Definitely want to acknowledge what J'vanete has mentioned. I think that acknowledgement is key. What does trauma look like? How many times have I had families come to me and say, I don't know why he started wetting the bed, and then I start asking questions, and I find out, oh, dad just got incarcerated. You guys just moved homes. There's several adversities there, and then I'm educating the family. Oh, these are real trauma. That's a little traumatic for him. He's only 8. He's only 9. He's trying to figure out the world. So I think that's important. I want to bring another point home. When we talk about, I just want to make sure, because I think when the A study came out, people thought, oh, those poor children, those poor children. And certainly, disproportionately, poverty has an impact and immigration has an impact. But we use the example of neglect. All of us are parents. And if any parent who has even partially experienced postpartum depression, which many women across the country do, up to 20% of women do, that is a period of time where you may feed your baby, you may change your baby, but you don't really have the energy to give that face to face energy back to your smiling baby. You don't have the energy to talk to baby. Many women experience that, and that can have an impact. Certainly, if we have a team and a village and other family members who are willing to come in and smile and talk to that baby, we can do the work. So that's part of that community, that village. What J'vanete describes is something I like to call the socio-ecological framework. It's looking at the individual and realizing that individual lives in a family, and that family lives within a community, and that community is governed by policies like family maternal leave. Is that there or is that not there? Last but not least, I want to bring up a study. It sounds so scientific, but I'm telling you, this blew my mind. It was a study that talked about the changes in DNA methylation for rat pups, of all things, who had been abused. We do a lot of studies on rats and mice. Well, this particular study took 3 groups of rats. They took a rat, had her babies, lived in her little space, her natural space. She had enough hay. She had all the things that she needed. The second rat was not the biological parent of these pups. She was a foster parent, but she had the hay. She had all the things that she needed. The third rat pup was also fostering these little rat pups. I'm sorry, the third rat mom was fostering these little pups. She did not have the appropriate hay. She had half the amount as the others. Well, guess what? In that third rat pup who did not have the sufficient things, she abused those babies. She stepped on those babies. She ignored those babies. She neglected those babies. And it was incredible to see. And the point of the study was to show that their brain changed, the methylation of their DNA changed. But the thing that was most poignant to me is how in the heck did they get this rat to abuse these babies? She did not have what she needed. So when we talk about that framework, we think about making sure families have what they need, that they're not so stressed out, that abuse is even on the menu, whether that means they have the mental health capacity to care for their children. Do they have the actual things, the housing, the food that they need? And do they have support? Do they have support structures around them? So these are all the things we need to consider when we're talking about preventing and mitigating the impact of trauma, but even preventing trauma altogether.
Thank you. That is truly a fascinating study. Thank you for sharing that with us. Um, we've talked a lot about trauma in people who are not teenagers. So, what does trauma look like in teenagers? Um, I know we were talking about teenagers a little bit before we got started. So, would anyone like to speak to that?
I can. J'vanete Skiba here. I think some of the behaviors that we're currently seeing being reported on across the board for our teenagers might actually be a good, um, a time for us to step back and really observe because we hear about issues with social media. We hear about issues with community and school violence with youth. We hear about issues of absenteeism. Um, this is really interesting to me because we can talk about teens and see all of these issues, And they're issues that have kind of risen to the top for teens always. But in light of COVID-19, which really did, and the lockdowns and shutdowns, it really did not create a problem, but it forced us to really look at a problem. And so some of what we're seeing, I believe, can be great examples of trauma response in young adults and teens. Um, and going back to what I mentioned before, we can get really caught up in those behaviors because they can be challenging. But in and of itself, the behavior is just an indicator, right? It's not the thing. The underlying thing is that that child, their nervous system, has undergone an assault. And that's really, to me, what trauma is our nervous system gets to a point of overwhelm and it adapts. Our brain adapts, our nervous system adapts to that overwhelm. And so maybe a teen who is trying to shut off the world can be a sign that they've experienced something that was potentially traumatic for them. We can't really say what can be traumatic for somebody else because the nervous system, the individual's nervous system, really calls the shots on that. But we can say for children across the board, this increase in community disconnectedness, even this increase in youth suicide, especially in North Carolina, we see those numbers. Those are really our indicators. That is what's showing us that many children might have experienced some potentially traumatic experiences in light of COVID, loss of that caregiver that we talked about before. As we know, lots of youth or many youth might have a caregiver that's not their parent who might have been elderly that succumbed to COVID-19. And we know that a loss of a caring adult, a stable adult in life, can be potentially traumatic. Also, that loss of social connection. It's almost like teens might be in overdrive now, wanting to engage in social media because if they don't, they are ostracized. Um, Engaging also because if they want to be connected and know what's going on, this is a vehicle of social connection for them right now. So that maladaptive coping mechanism of scrolling and constantly being on social media in an unhealthy way could also be an indicator. But what we really want to make sure is we're watching those relationships. Are they having connection with healthy, safe adults? Are they having opportunities to have the good kind of stress, problem solving, engaging in social interaction face to face, where they might actually have a little bit of conflict, but are able to problem solve and get past that conflict? All of those things actually help increase brain health and help us make those circuits, those connections in our brain that help us become more resilient. And in the absence of those things, we might be seeing some of the effects of teen and youth trauma.
I honestly thought of COVID-19 as being a traumatic childhood event, but the way that you worded it was slightly different. You said that it wasn't a traumatic event in and of itself, but it brought a lot of things to the surface. So thank you
And
for
it could
expanding on
be,
that.
yeah, COVID could definitely be like an environmental event, but um, we I don't want to directly go to that because in that a lot of kids might have had more connection with their parents because they had to stay home.
Mhm.
But really just as it kind of giving us that magnifying glass on things that were already festering under the surface.
Right, because some children may not have had food insecurity,
Exactly.
and their COVID looked a lot different than children who did not
Exactly.
have any. So, yeah, that makes a lot of sense. Thank you very much for saying that. Dr. Tribie Reid, did you want to add anything about what trauma looks like in teens or what your
Yeah, Dr.
experience has
Tribie
been?
Reid Reid here. I do, something that J'vanete said reminded me of a recent patient encounter. I have this relatively eloquent 16-year-old fellow who was really just getting in trouble in school. Maybe he's skipping class, maybe he's walking out of class, increased defiance, lots of things. And finally, when I got him alone, I said, what's going on? And are you sad? And he said, I feel nothing. And I said, what do you mean? He said, I feel nothing. He said, honestly, I try every day hoping that things will get better, and they don't. This is a child who was experiencing monumental amounts of trauma. And he said, every day, he said, the stuff, the walking out of school, the, absenteeism, that's what y'all see. That's just what y'all see. I mean, literally put into words exactly what Jay just described. That's what I'm showing you guys. That has nothing to do with what's really happening inside of me. And so I just felt like this was just the most eloquent way a child could have expressed what he was experiencing. So certainly those actions of defiance, those things that we think get on our nerves, they're teenagers that get on our nerves, but some of those things are a response to trauma. And I think it's really important to know the context of the individuals we're working with. And sometimes we have to work backwards and say, why is this child climbing under the desk? Why is this child walking out the classroom? And we have to say, he's not just being bad. Maybe there's something happening there. So we do have to kind of reverse engineer and ask the questions. But sometimes we know the context. We know that a parent just passed away. We know that this family just was evicted. We know that there's violence in the community in which they live and shots were fired, overnight. And if that is the case, we should understand that that's traumatic. And there may be some behaviors that go with that. The other thing I would say in teenagers is I see a lot of, especially in females, a lot of somatic complaints. So what that means is teenager comes to me and she says, my head hurts, my left toe hurts, my stomach hurts, and my back hurts. And I'm thinking none of those have anything to do with each other. I can't put it together. This is not a sick child. Not a child with a lot of chronic medical conditions. What's going on? And as I dig in, if I offer therapy often, if they agree to therapy and continue to go, all of those symptoms fall away. So those are often kids who are dealing with depression, but maybe also responding to some trauma. So I think that would be the most common thing I see.
Thank you. So how can parents help their children to deal with childhood trauma?
I'll jump in there. This is Dr. Tribie Reid. I think being a safe, consistent, and nurturing caretaker, I think it's important to state families can go through hard times. Families can go through poverty. They can even experience community violence. We would rather them not. But if they know that that caregiver is coming home every day, or they know what to expect out of their caregiver, or they know that they have a caregiver, often that is sufficient to mitigate and buffer the impact of trauma. So just being consistent, being present, I think is the most important thing.
Thank you.
J'vanete Skiba here. I completely agree. We really underestimate the importance of relationship and connection. It is not an abstract, emotional, and I put emotional in air quotes, experience that we offer each other. Connection, and I'll say it 100 times, is really our first survival response. If we're thinking back to early brain development, everything that our brain builds its foundation on starts with that primary attachment, that connection. And when we don't feel connected, the parts of our brain that signal threat and start that stress response get activated. And so if I really want to be a protective factor in my child's life or in the life of the kids that I have the privilege of being around, then I want to lead with connection. And really, it's not hard to show up for a child. Children don't expect much. And so when we engage consistently, just like Dr. Tribie Reid said, a kind word, if you're not someone who's able to be with this child all the time if you're not a parent. Just having somebody at school who says hi to you on a regular basis, authentically and genuinely concerned about how your day is going, then that is a protective factor. That could really change an outcome for a child who might be experiencing some adversity. And to speak to something else that Dr. Tribie Reid said, we get caught up oftentimes in deficit mindsets when it comes to material things, and we miss the very material process that's happening in our brains when we have those close relationships. So if I have a deficit or a lack in the food that I get to eat every day, or in my housing, what makes me more resilient or allows me to bounce back, or actually, I've heard more recently to bounce forward as I experience this adversity, is just the relationship. You can take a child who has no safe adult relationship, and a child who does have a safe relationship, and the same material experience as far as housing and food. And the child that has a connection is likely to fare better than the child that doesn't have a connection. Same material environment, but different as far as their relationship and that connection. Not that we want to continue and just say, oh, well, that family's resilient and their parents are connected. We don't have to worry about the food or the housing insecurity. I'm not saying that at all. But what I'm saying is each of us individually have an opportunity to help mitigate some of that potential long-term effect of that adversity, just by building connection. So that's like our step one as we change systems for everybody. Just starting there is vital.
Uh,
I do want to jump in on that, if you don't mind. This is Dr. Tribie Reid. I agree wholeheartedly. And I spoke about parents or caregivers. A parent, once again, it doesn't have to be a parent, whoever that caregiver is, aunt, grandma, whoever. But a safe, stable, nurturing relationship can be any member of this community who is consistently in that child's life, and that does improve resilience. So for me, I've had many families, unfortunately, who I've watched be with their biological parent, go into foster care, maybe go back to their biological parent, or maybe go into adoption. But I was their pediatrician the entire time. So this was a safe, stable, nurturing space for them. Same with coaches, same with teachers. We can probably name our own safe, stable, nurturing relationships we've had in each of our respective communities growing up. So this is a huge thing because we don't want to put everything on parents. I think the other piece of that is softening the blow for parents, not only with policy, but with our presence. I mean, I just remember being a parent and how grateful I was if somebody in the grocery store said that baby's hair is so pretty. Like it would just light me because I didn't know if I was doing this thing right called raising my baby. So it really decreased my stress. So really being a community of people trying to raise up healthy humans is something that I think we need to reach for.
Thank you very much for that. Are there resources in the public schools to help children dealing with trauma?
J'vanete Skiba here. Yes. We have great mental health professionals in our public schools. Now, I know that there's been a lot of talk on maybe there being some destabilization there. But with community, other organizations in the community and collaborations, um, children are being supported. Um, and not necessarily just with mental health therapists. There are other organizations who bring, just like Dr. Tribie Reid said, those stable, healthy adult relationships and connections. So we are grateful for that. Schools cannot do this alone. It is important for all of us to be that support, regardless of political climate or all of those things that can color the experience for administration, for teachers, and for students. It's important for us as community to make sure that we expose all of those collaborations and things that are going right to help support students. There's always more needed. My pie in the sky is for every school to have mental health and behavioral health supports proportionate to the student body and the student need um, individual for that school. You know, my pie in the sky is not for schools to have to share um, mental health professionals specifically because that person gets to know very intimately the needs of that student body, the needs of the faculty and administration, and the communities that feed those schools. So that is a pie in the sky for me. But yes, there are supports. Um, and then thinking back just to how we take care of educators, that's one of the supports that we need to make sure that we're advocating for as well. Because the conditions in which our educators and administrators work are the conditions that our children learn in. And we know through science and studies that when teachers are taken care of, then that changes the trajectory of how students actually perceive their school experience. It increases their likelihood to stay in school and to stay engaged with academics when teachers are well and taken care of and feel equipped. Um, so again, there's another opportunity in our schools where children are actually getting what they need when we take care of staff and faculty and administration.
So, if someone is listening who is not forward facing with children all of the time, or it's not an educator or a physician, or working with the New Hanover Resiliency Task Force, how would you tell them to volunteer or donate if they would like to help with some of this? Is there an organization that you would point them to?
I'll ask
J'vanete,
J'vanete
oh,
to address that because she's working with so many different entities in the community.
sure. There are lots of opportunities to get connected. There are organizations in our community that offer after school tutoring. They offer EOG um, tutoring and preparation for students who need that extra help to be successful in their EOG. There are organizations in our community that engage other community partners and businesses to have individuals come and spend time and mentor students as they support them in math or reading. Um, I hate to name just a few because there are so many I can name, and I know that I'm going to leave some out. But so people can get connected and not to the exclusion of any other. I will actually share some resources on the back end if I can, but just what's top of mind. Um,
I was going to
there's
ask too, is if they go to your website, are there resources listed there?
Absolutely.
Okay.
Absolutely. If you go to our website, which is nhcbouncesback.org, you will see a large logo of all of our partners um, that support our schools and educators. So that's the best way to figure out how you can be helpful and to know you don't have to be an educator. You know, spending an hour a week could be really helpful for our students and educators.
Thank you very much for that. Dr. Tribie Reid, did you have anything to add about the resources in public schools?
No, I don't, but I will take a step back and say when you asked about the public schools, JVNA and the Resilience Task Force have been really instrumental in introducing the vocabulary, helping us understand how our brain works, how brains respond to stress. And I think in so doing, they've really helped to provide teachers, administrators, context to understand the behaviors of their students. Changing culture is huge. And Dr. Jarrett, you may remember being in med school and hearing parents and hearing us as medical providers or our attendings blame the parent over and over again. Oh, I know that parent smoking. I can smell the smoke on them. We were constantly really putting the onus on parents, which rightly so to some extent, but it's a wider context. And I think this work and this vocabulary acknowledges the wider context that is when we talk about trauma and behaviors and symptomatology and all of these things.
Do you sometimes refer families to therapy? Is that something that you do to help with the childhood trauma, or what do you do when someone comes into your office and you know that someone is dealing with childhood trauma?
Yeah, once again, often families are coming in with complaints of behavior problems, or maybe I find out that adolescent is depressed. These are some of the most common things, or maybe I hear in the conversation, it's just conversation, but by and large, I hear all these little darts of trauma that they're throwing at me. And yes, I absolutely do say, can we work with somebody? Sometimes the kids are already working with someone in the school system. All right. Coastal Risings has a great program, especially in the high schools. With COVID, there were mental health providers placed in the schools. And so those were resources, but we also, of course, have integrated behavioral health here at Med North. And often, certainly if it's urgent, I can have someone come right in the room to make a face-to-face and a warm handoff to get that process started of getting to know a potential behavioral health provider. So absolutely, that is one of the things we do. We also just try to make sure families have the supports that they need. So do they need food? Are they mentioning domestic violence? What other resources can we provide to give them enough hay to feel comfortable that they can do the work that they need to do in raising their child?
Very good. Well, thank you, ladies, so much. This has been a wonderful conversation. I have learned a lot, and I have a lot of resources. I hope that everyone else who's listening today feels like they are walking away with a lot more information about childhood trauma and what we can do as a society to improve that. I would like to give you the opportunity to leave our audience with just one little bullet point, one thing that you want us to remember. Dr. Tribie Reid, you're on the screen, so I'm going to let you speak first.
All right. Well, it's been a pleasure to be here today. Thank you so much for having me. Certainly, I think the biggest thing is that we are trying to raise healthy humans, humans who are responsible, who can raise other healthy humans. And the onus is on us as adults, as potential caretakers, and as potential safe, nurturing spaces. So I ask us to take a communal approach and not think of that as their child over there, but our child as a community.
I love that. Thank you so much for that. J'vanete Skiba, would you like to leave us with one special points?
Yes, I love what Dr. Tribie Reid said, and it makes me think just all our children are all our children. I keep hearing that, and it is so, I find it to be true. And one thing that I also find to be true is that when we think about trauma, especially childhood trauma, some misconception is they won't remember it. And memory is not the issue. Okay. It is really that physiology, that stress response, everything I mentioned earlier about what happens in the brain early on. And so, even if a child is in air quotes, too young to remember, their body will always remember. And if all our children are all our children, then we need to be building that connection so that they feel that safety and so that they can heal.
Thank you so much.